Hello everyone, and welcome to another audio podcast in this series, the Rogue Storm episode. This is the Shientist, and today I'm going to talk about massive transfusion regimes, and as part of this audio podcast, in line with the series relating to aspects of pathology and laboratory medicine. This is another Storm Robotics production. So to start off, a bit of a definition, really. So massive transfusion is defined as the administration of enough blood, in particular when relating to blood, mainly red blood cells, so enough blood all components within less than 24 hours to constitute a complete volume replacement. So thus, individuals or patients who require red cells or blood components, they do not fall they don't they are not at risk. There's no probable risk that they fall into hypovolemia. So, in relating to this, you have some physiological results of what happens when individuals and patients fall into a hemorrhage. So you can have changes brought about by acute hemorrhage, which is typically referred to as hypovolemic shock syndrome, and the symptoms typically include decreased blood pressure or hypotension. There's rapid and what's referred as a thready type pulse, where basically the pulse of individuals or patients are barely readable. And then there's an increased respiratory rate as well, and there's a constriction of the peripheral blood vessels, producing cold and sort of a clammy feeling to the skin. So many factors affect the amount of hemorrhage that will produce hypovolemia or shock, but a rapid loss of around between 15 to 20% of blood volume leads to shock in most individuals. So almost all patients with hemorrhagic or hypovolemic shock have generally lose around 35 to about 40% of blood volume. So one of the first responses of the body, or from a physiological perspective, is to shift fluid from the extravascular spaces to the circulatory system. This stabilizes the circulation, although the fluid possesses neither the oxygen carrying capacity lost, nor the osmotic properties of plasma. So in this regard, as a result, there are hematological parameters that are affected, and typically hemoglobin drops. There's a drop in in something that is referred to as hematocrit, and there's also a drop in the red cell for blood count. Dilution of blood, or blood in relating to blood volume, also begins pretty much immediately through a hemorrhage, and continues up to 72 hours after the bleeding has stopped. So basically, through physiology, the red cell volume decreases, and as it decreases, there's a dilution, which means that the blood, the efficacy of the blood, or the potency of the blood within a hemostatic perspective, there's a dilution, which means that the blood volume that is left within physiology, it generally causes issues where patients or individuals do not have enough blood volume for particular functions that would normally be carried through normal physiology. So during roughly a sort of a three day duration, whilst patients or individuals are having issues with have issues around hemorrhage, for example, during an average of a three day duration, the hemoglobin and hematocrit values are pretty much unreliable, because they do not reflect the total amount of bleeding during this time. In the first few hours of active bleeding or active hemorrhage, hemoglobin and hematocrit values may be misleadingly high, despite obvious blood loss. So from a laboratory perspective, the full blood count can be false, can be false positive. Hence why it is important for health professionals to provide as much information as possible relating to individuals when a full blood count request is required, but also in relating to, for example, when requiring blood for replenishing red cells. Generally, health professionals should be aware of how the full blood count can generally be affected as well. Individual hospitals, different hospitals regionally and nationally even, will usually introduce a regime to follow in the event of a massive transfusion. And so the overall aims is to restore blood volume, and mainly from what would be a hypovolemic state to a hemopoiesis or hemostatic blood volume, and to restore hemostatic competence if deficient, thus replenishing primarily the red blood cells or red cells, but also through replenishing the red cells where other parts of cell components are concerned, that they are replenished if required as well. Generally, there are guidelines in pathology and laboratory medicine. There are guidelines allow the issue of particular blood components without reference to without a reference to a consultant, as long as there is a sort of there is a healthcare professional on the front line who's sort of managing a hemorrhage where applicable. Then generally the guidelines are standardized so that generally those who are health professionals on the front line, alongside with pathology and laboratory scientists as well, that a massive hemorrhage can be dealt with in a timely way. I also wanted to take the time to highlight some aspects in relating to more specific clinical decisions to transfuse, and some of this context has been highlighted in peer review works, and so I thought I'd take some time to highlight some of this context as well. So clinical decisions are clinical decisions to transfuse are different or vary between different hospitals, regionally or nationally, and so clinical decisions are still challenged or questioned relating patients understanding and professionals having the knowledge about transfusion practice or transfusion guidelines, personal experiences with transfusion, and attitudes and beliefs about how best to manage, for example, anemia alongside a hemorrhage in patients with a long-term condition or chronic illness. Now, biomedical laboratory techniques and research has developed over time, especially with respect to blood grouping and cross matching. Several authors in works have highlighted or indicated that failing tissue oxygenation would be ideal to guide the need for transfusion, but this modality has not been proved effective, reproducible, or sensitive to regional tissue hypoxia. So generally there are sort of alternatives. However, particular aspects of transfusion, but the efficacy and the potency does not replace the requirement for red cells, and the clinical importance of red blood cells, or the requirement for RBTs, or red blood cell transfusion, and storage around them is time dependent, metabolic, biochemical, and also the sort of research around sort of the red cells and the time between a hemorrhage happening or taking place and an approach to requesting red blood cells is still not being clearly, it's not transpired in literature quickly, although in a massive hemorrhage ideally a quick a quick response is required. So in line with that, RBTs or red blood cells, RBCs, can be filtered, washed, frozen, or irradiated for specific patients and to meet particular or specific indications where a hemorrhage has been identified. Donor screening and testing have dramatically reduced infectious risks in the developed world, making transfusion more accessible. But infection remains a major hazard in developing countries where, for example, 13 million units of blood are not tested, are not all, and have not been tested for, or at least in literature has been highlighted that 13 million units of blood are not tested for human immunodeficiency virus or HIV or hepatitis virus. And despite serious immunological and non-immunological complications, red blood cell transfusion or RBTs still hold a therapeutic index that exceeds that of pharmacological alternatives or interventions where red blood cells or red blood cell transfusion replacement is concerned. And in line with this, different transfusion alternatives are known for pre and intra and post-operative periods. Autologous blood donation and erythropoietin based pharmacological stimulating agents are efficacious in the pre-operative duration. Intraoperatively, acute normal volemic hemodilution, cell salvage, antifibrinotics, and specific anesthetic and surgical techniques, coagulation monitoring, and acceptance of minimal hemoglobin values and artificial oxygen carriers can reduce the requirement for allogenic red blood cell transfusion. In the post-operative period, cell salvage, antifibrinotics, and accepting the minimal hemoglobin values are some of the steps, that have been implemented so that practitioners, laboratory professionals, and healthcare professionals on the front line can reduce the requirement for more red cells than actually really needed. Alternatives to red blood cell transfusions should be given strong consideration. However, more focused evaluation of specific long-term conditions and chronic illnesses that patients have in line to population health and transfusion alternatives will help to clarify best use of treatment options, taking into account specific aspects of laboratory parameters. So, for example, where patients or individuals who might be susceptible or who might be suspect or high risk for conditions, for example, acute kidney injury, which can cause problems in relating to blood transfusion practices as well. Some clinicians, however, can sometimes overlook the need for component therapy, whilst others make excessive demands. So in either case, however, the medical help should be sought. So thus the pathology department has main procedures, and those who are involved in where there might be a hemorrhage evident should refer to the pathology and transfusion specialist as to how to request the appropriate units against particular laboratory parameters, and to ensure so that's to ensure effective use of red blood cell components or other components where and if necessary. In line with this is also that a coagulation screen and a full blood count or platelet count should be checked when, for example, there is a multi-site bleeding at any time, and for example, once one body volume transfusion is given. So, for example, typically anything between 8 and 10 units in any one particular time. So coagulation screening is absolutely important, so thus to give indication as to whether other components, other blood components are required. It is worth remembering, as part of this, that coagulopathy of massive transfusion is more closely dependent on the duration of hypovolemia than the volume of blood transfused. So monitoring hypovolemia is alongside coagulation is absolutely important, so thus to ensure that patients and individuals are not, for example, being over transfused if transfusion is required, or do not receive, or there are not enough blood components or red cells, for example, as well. So there is in literature there is sort of evidence. However, it's little evidence that, for example, from a historical point of view, that prophylactic replacement with fresh frozen plasma or platelets will prevent the onset of abnormal bleeding or reduce the need for red cell transfusion. So generally, again, from a practice perspective, it is important that, again, hypovolemia is monitored alongside full blood count, and ensuring that the patients respond to the particular red cells, red blood cells or blood components that are initially requested, if abnormal bleeding if abnormal bleeding continues. And so prophylactic replacement with fresh frozen plasma and platelets are not necessarily going to help in a massive transfusion hemorrhage, or a massive hemorrhage, or massive bleeding, when red cells are being lost primarily. So once again, I want to say thank you for tuning in on this audio podcast in this series, the Rogue Storm episode. Here is sort of one main reference, but also a few acknowledgements that I'd like to make as part of this audio podcast. So one of the main references that I used that have been used is the International Society of Blood Transfusion ISBT Science Series 2020, and it's as part of the special science series special issue Introduction to Blood Transfusion from Donor to Recipient, and it's available from the International Society of Blood Transfusion and is accessible, and it's freely downloadable. And I'd like to say a few acknowledgements. I want to Malcolm Nees, transfusion scientist and practitioner UK for the approach to hematology. Another acknowledgement to Professor Ken Jones, for Emeritus Professor in Immunology UK, for the immunology perspective. Acknowledgement to Julie Molloy, NHS Blood and Transplant UK, for the blood and transplant perspective. And finally, I want to just highlight that there is the next audio podcast in this series on the Rogue Storm episode will be about pediatric transfusion. The one after that will be around pre-transfusion testing, and then the one after that will be around the provision of blood for bone marrow transplant patients. And then there will be an audio podcast on the use of plasma products, and an audio podcast on thrombophilia. So thank you again for tuning in. This has been the Shientist and another Storm Robotics production. Thank you for taking the time.